Hi, this is Carl Nibley, cardiac electrophysiologist at John Muir Health, here with a clinical update regarding the management of atrial fibrillation. As everyone knows, atrial fibrillation is the most common arrhythmia encountered in clinical practice, and it comes with three very important clinical concerns. First, the risk for cardioembolism with stroke. Second, the disabling symptoms that frequently accompany the arrhythmia. And third, the concern that some patients will develop a cardiomyopathy related to persistently elevated heart rates and the subsequent development of congestive heart failure. It's very important to reduce the risk of cardioembolism with stroke, and we rely on the CHADS-VASc clinical scoring system to help assign appropriate stroke mitigation strategies for patients. For patients with elevated CHADS-VASc scores, we often recommend the newer direct oral anticoagulant medications. Although warfarin remains available and is appropriate for some patients, in general we prefer the newer agents whenever possible. For those who can't use anticoagulation, we're also recommending left atrial appendage occlusion or ligation. The occlusion procedure comes in the form of the Watchman device, which is placed transvenously in the cardiac catheterization laboratory in a 1-hour procedure. Patients are kept in the hospital overnight and discharged with minimal sequelae. For those who are not candidates for the Watchman procedure, the cardiothoracic surgeons are able to offer a thoracoscopic version of left atrial appendage ligation. It's very important to manage the arrhythmia itself aggressively, and we increasingly rely on catheter ablation strategies for this. Most of the ablation procedures that we perform use the cryoballoon for pulmonary vein isolation, but we also have radiofrequency ablation that remains useful also for pulmonary vein isolation and to place other lesions in the left atrium that help to decrease the likelihood of further atrial fibrillation. The ablation procedures now last just 1 or 2 hours, which is a sharp reduction from the duration of the procedures that we used to perform. This is done under general anesthesia, and after 1 night in the hospital, patients report excellent procedural tolerance, and they return to their usual activities very quickly. The ablation procedures are not 100% successful, but almost every patient experiences substantial clinical benefit from the ablation procedure itself. Part of our aggressive management strategy includes heart rhythm monitoring. Historically, we used 24 or 48-hour Holter monitors. Now we have extended patch monitors that can be worn by patients, or implantable loop recorders for those that want prolonged monitoring. Those devices are placed under the skin and can last for 3 years. They come with remote telemetry, giving us day-to-day information regarding the rhythm status for patients. For other patients, we have wearable devices that they can purchase and use to monitor their heart rhythm status at home. As with almost any medical condition, we would prefer to see the patient and design a proper treatment program at the earliest stages in the arrhythmia progression. This gives the patient the best opportunity for elimination of their symptoms and, in some cases, complete elimination of the arrhythmia itself. If you have a patient with atrial fibrillation, or you're concerned that the patient may be experiencing atrial fibrillation, I would encourage you to refer the patient for cardiovascular consultation either to a general cardiologist or directly to an electrophysiologist at John Muir Health.